Namaste and greetings. I, Priyanshi Arora, am a researcher at IMPRI, Impact and Policy Research Institute, Prabhav Evam Niti, Anusandhan Sansthan, Nai Delhi, and I extend my warmest welcome to all of you to the IMPRI #Web Policy Talk. Today, we have gathered for a special talk on the topic, the state of demographic and health data in India, by Professor Usha Ram. As a part of the series,
Hello.
The State of Statistics,
Hello.
#Data Discourses by
Hello.
IMPRI Generation Alpha Data
Andy.
Center. Our event will be chaired by Professor Purushottam M. Kulkarni. Professor Purushottam is a demographer who was awarded a PhD degree in statistics by the Colorado State University and was a postdoctoral fellow at the Brown University. Professor has worked in various research and educational institutions in India, and he retired as a professor of population studies at Jawaharlal Nehru University. His areas of research interests are technical demography, fertility, reproductive and child health, sex ratio at birth, and population policies and programs. Sir has published various research articles in journals and is a co-author of the book Population and Reproductive Health in India, an assessment of current situation and future needs. We welcome you, sir. With the permission of our chair, I would like to introduce our speaker. Professor Usha Ram is a professor in the Department of Public Health and Mortality Studies and the coordinator of short-term training program and publication cell at the International Institute of Population Sciences, Mumbai. Usha ma'am was awarded the CIHR Hope Fellowship by the Canadian Institute for Health Research, Canada. She worked at the Center for Global Health Research, St. Michael's Hospital between 2011 and 2015. She earned her doctorate in demography from Mumbai University and has 2 masters, one in population studies from IIPS Mumbai and second in economics from Rajasthan University. Ma'am recently developed district-level fact sheets for tribal health indicators being used by Ministry of Tribal Affairs for developing local policies and programs. Professor Ram is currently the principal investigator of the Exemplars in Global Health National and Subnational Investigation of the Drivers of Success in Maternal and Newborn Mortality Reduction in India, in collaboration with University of Manitoba, National Health System Resource Center, and IHAT, funded by Bill and Melinda Gates Foundation. Usha ma'am has published over 100 articles in international and national journals, and her work mainly focuses on mortality estimates at subnational level, maternal and newborn mortality, mental health, gendered nature of sexual and reproductive health, and demographic health surveys of tribal and minority health. Professor Usha has developed a new method for estimating age gender-specific mortality for Indian districts using multiple data sources adopted by several countries, including Ethiopia, Mexico, and Brazil. Professor Ram has worked in several capacities for various international and national organizations. Ma'am was a UNFPA consultant to analyze the mortality data from the 2014 census of Vietnam. Professor Usha is the co-chair of Child Health and Infectious Disease, Center for Global Health Research, St. Michael's Hospital and University of Toronto, and a member of Nutrition Committee of Indian Council of Medical Research, India, and Joint Secretary of Indian Association of Study of Population. Usha ma'am is on the advisory board of Lancet Eklund Medicine, a reputed global public health journal, and ARPAN, an NGO working towards the elimination of child sexual abuse in India. We welcome you, ma'am. Our discussants for today are Dr. Rattan Chand, Dr. Manorama Bakshi, and Dr. Srinivas Goli. Dr. Rattan Chand retired as Chief Director of Ministry of Health and Family Welfare and was the former Deputy Director General of National Accounts Division and the former Director at National Sample Survey Organization, Ministry of Statistics and Program Implementation for Government of India. We welcome you, sir. Dr. Manorama Bakshi is the head at Health and Advocacy at Consortia Advisory in New Delhi. We welcome you, ma'am. Dr. Srinivas Kohli is the assistant professor at Center for the Study of Regional Development, Jawaharlal Nehru University, New Delhi. We look forward to learning from all of you. I would now like to hand over to our chair, Professor Purushottam Kulkarni, for his opening remarks and to invite Usha ma'am for our lecture. Thank you.
Thank you, Priyanshi. I'm glad to be here, and my thanks to the IMPRI for this kind invitation to listen to the lecture by Dr. Usha Ram. At the outset, I must say that the topic is of interest, the state of demographic and health data, for various reasons. In the long back, more than 100 years ago, there really wasn't much of demographic and health data. Essentially, what we had was census and sanitary commissioners' reports and a few other things. In fact, many people said that census was also there primarily for administration. However, over time, we have seen that census data are very useful, not just for administration, but for development, research, and so on. However, the data availability was quite limited. But over years, there have been changes. First of all, the civil registration system, which covered only a few areas and registration was optional, has been made compulsory, though it has not yet become universal. In the past, only a few areas like Berar had good registration. Over time, things have improved, but they are nowhere near satisfactory. Yet, we do have a lot of information from that. Because it was not satisfactory, the sample registration system was introduced, which has been fairly satisfactory, but of course, not perfect. No system so far has been perfect. But what has happened over the years is we have information, or what we call broadly data, from a large number of surveys. The Mysore population study was a pioneering study in the world. In fact, it was done in India in the old Mysore state in 1950s. But there have been studies by a large number of organizations. The population research centers in the Gokhale Institute, in Gandhigram, in Delhi, and so on, have been doing a large number of studies. Many of them are for smaller areas, districts. Occasionally, for the state as such, we had the standard fertility surveys. And over time, we have been collecting a lot of demographic data. The National Sample Survey also collected some demographic data initially, but later on, they stopped doing it and started getting data primarily on health in certain rounds, normally once in 10 years or so, more on expenditure and useful for expenditure and so on. But what happened over time, especially in the 1990s, was a series of national surveys, what we call the National Family Health Survey. This really is an outgrowth of the old world fertility surveys, which were primarily on fertility, became demographic and health surveys, where health aspects got covered. And in India, we call it the National Family Health Survey. So we have had now 5 rounds of it, which have given a wealth of data, enormous data. And the advantage of the National Family Health Surveys from the beginning, from the first round, is that the data are available to researchers. So they are not just for administration, they are useful for research. And this has been the tradition set by the NFHS, later on followed by the NSS also. In addition, we had a number of other surveys. We have the district level surveys. We have national surveys by the census office, sample registration, and surveys on special population, elderly, like Lassie, youth, surveys especially on youth. This has been, we had surveys on nutrition. In addition, data on health aspects, we have much more of it than in the past. There are a large number of notified diseases from which we get data. And of course, the government, both the state as well as the center, do provide us data on health services, health infrastructure, and also events, including recently the COVID and so on. Plus, we have the service statistics, which are now being very much standardized, at least over the last 10 years, in the form of what is called a Health Management Information System, or HMIS. So now we have a lot of data from census, sample registration, civil registration, service statistics, hospital statistics, special information systems, and of course, various other studies and so on. Now, having multiple sources is a good thing, but at the same time, one also has to see that one doesn't get lost in the multiple sources, because ultimately what we need to get is extract from these what is information as accurate as possible and as useful as possible. So one has to be selective, one has to look at the quality, one has to assess the various data sources, and then see what is it that we can make out of all this data. And therefore, it is important that we look at the state of the demographic and health data. What do they give us? Where there are weaknesses and where there can be improvement, what is something which is required. Of course, I know that in 30 minutes, it is not possible to cover all of these aspects. It's a tall order, but I'm sure Professor Usha Ram, with her expertise and with her own in-depth work on various areas of this, both population as well as health, would tell us the essence of it. What is it that we can get out of it? What is it that we should do in future? And how we can best utilize the available data. So with this opening remarks, I would like to request Professor Usha Ram to begin the presentation.
Arjun, would you be sharing the PPT, please?
Yes, ma'am. I'm just bringing.
Thank you. Thank you. Thank you all. Thank you, Professor Kulkarni. A very good evening to all of you. At the outset, I express my sincere gratitude to Dr. Arjun, Director IMPRI, for giving me the opportunity to share my views on demographic and health data in India with these learned participants here in this event today. When Arjun wrote to me asking if I would be a speaker for the IMPRI special talk series on the state of statistics, first thing that came to my mind is that I should take this opportunity and share knowledge and the struggle both of the demographers working in the area of mortality and public health. As a social scientist and researcher, I have often faced data crunches due to non-availability and sometimes due to inaccessibility, especially when it comes to estimating health indicators for smaller geographies and population subgroups. So I immediately agreed and wrote to him that I would like to talk on state of demographic and health data in India. We finalized the theme and here we are today. Friends, I'm looking forward to your insightful feedback on my presentation. As elaborated by Professor Kulkarni, a lot of things can come under health, but given the time constraint, I have restricted my presentation largely dealing with issues of data for mortality and morbidity. So that is where my focus is going to be, and restricted to 6 to 7 key data sources that are currently available in India. So that's just an outset that I want to bring out to everyone. When I started thinking of this presentation, I remember my days in IIPS as a student, which was in mid-1980s. During most of our classes, in the lectures, our teachers would teach us that most of Indian health and family welfare programs and policies had only limited success as they lacked evidence-based planning. This was because the policies were far from the ground realities and local needs. And I used to wonder as a student, why does every teacher say so? As I progressed into my academic higher studies and decided to focus on a small area estimation for my doctoral work, I realized that I just don't have the data that I need for my research. And this made me to recognize how important the data is for us researchers particularly. Until early 1990s, and as a student, through my student life of spending over 6 years at IIPS, census was the primary data source for us demographers, and that too in the form of published tables only. As many of us would know, the unit level census data is not accessible publicly to anyone in India. I must thank my alma mater IIPS, which revolutionized the face of and access to demographic and health data in early 90s after it initiated first round of NFHS at the state level, and later with the launch of DLHS in the late 90s at the district level. And they just did not initiate the effort. They also set a landmark, and by making the data publicly available, free for all at unit level, raw data. And that is something I think, as Professor Kulkarni also mentioned in opening remark, was a landmark, I would say, in data, health data in this country. At the outset, I want to inform you that I would present my presentation only related to demographic and health data needs, which are about population health coverage only. I should not talk about supply aspects of health data, which relates to infrastructure, etc., simply because of the time that I have at my disposal. Now, coming back to the, you can go to next slide, please. Yeah, coming to the evidence-based planning for improving population health and well-being. What does it really mean? As I understand, it means we must be able to quantify health indicators in a reliable manner. Choice of health indicators is quite wide. However, the most commonly used measures include crude death rate, age-specific death rates, infant mortality rate, under 5 mortality rate, life expectancy at birth, maternal mortality ratio, top 10 causes of death, prevalence and incidence of diseases, and sometimes disease-specific fatality rates. The next important aspect to me about data is, should health data be measured at one point, or should we have time series estimates? I think time series estimates are always better, as they allow us to understand how changes are taking place over the period. In some condition, like pandemic that we currently are facing of COVID-19, for example, we just not only need data, but we need data in real time, and that too disaggregated data for timely action as well as decisions. Next slide, please. Now, is this adequate? My answer is no. Supposing if I have all of that, what I have just now mentioned, probably my answer would still be no. I believe we need lot more than what I have stated in my previous slide. When I say more, I mean that the data at the national level alone or for the total population is not adequate. We need more and more disaggregated data at the lower administrative units, and I would say even below district level, that we should try, whether it is for the blocks or even for the cities, towns, panchayat, and so on and so forth. In addition to that, we should also have the disaggregated data for population subgroups based on socio-economic demographic characteristics such as urban-rural residence, gender, religion, caste, wealth, to name a few. The advantage of disaggregated data, as I see, is that it allows us to identify laggers, measure inequalities, and that facilitates actually plan for area-specific and local need-based strategies in interventions. Next slide, please. Now, there are few basic questions that I would want to raise before I go into the data availability, which are very basic from the researchers and policymakers' perspective. I shall discuss about each of these three aspects in my today's presentation when I go to each individual source of data. And these questions that I'm trying to raise are relate to how comprehensive the data that we have each, what is the quality of data, and how accessible the data is to us researchers and to other interested in understanding or exploring the issues around population, health, nutrition, and things like that. Next slide, please. So when I say comprehensiveness of the data, what I mean is that we need to understand the situations from as many indicators as possible. It doesn't mean that we have all indicators. That would be ideal, of course. But given the ground realities, I think the minimum that we can think of is to have indicators, which I'm listing out below, that would still allow us some insights related to population subgroups in order to make our area and subgroup specific needs for interventions and planning. So for example, for mortality, it would be useful if we have age-specific death rates that are disaggregated for smaller geographies and population subgroups. Data on age-specific major causes of death would be, of course, an icing of the cake, but I'm not very hopeful about that in the current scenario that we have in this country. For morbidity, understanding of prevalence and incidence of common diseases by population subgroups would be useful to begin with. Next slide, please. When it comes to the quality of data, it is very important, as all of us would understand it. And when I say quality, I'm looking at following aspects. Is data representative? Does it include all sections of the population? Does it cover marginalized groups? Does it cover difficult terrains? How scientifically data has been gathered? We have to evaluate the data on these scales before we can make use of the data for any analytical or policy purposes. Equally important is to understand what is the quality of data that is reported by the respondent. And for that, we need to understand, does data suffer from any obvious reporting, such as digit preference when it comes to, for example, age data, which is critical for all our analysis that we do in demography? Or is data having a bias because of socially acceptable responses, whether it is constrained with the non-disclosure of information, particularly for diseases that have social stigma, for example, tuberculosis, leprosy, reproductive tract infections, sexually transmitted infections, HIV, AIDS, etc. Next slide, please. The third aspect is about the accessibility of data, which it may so happen that the data may exist actually, but the users may not have access to it. And I clearly remember a few cases where this is true, where the data we know is available, but is not accessible to the common researchers. Only the few privileged ones have access to the data in this country. And that kind of thing, I think I'm not for it as an academician. Further, I think it is very important for us to ensure that the data that we have got on population and health also has information on factors associated with mortality and morbidity, and allows researchers to answer key questions like, why are rates higher in an area? How the rates have changed over the period? What is that has led to the change in these rates? How some populations have succeeded in bringing down the mortality and morbidity burdens as compared to others? Or why some areas have still not been successful in reducing their mortality and morbidity burden? Next slide, please. So there are plenty of data choices in this country. It is not that we just don't have the data choices, but each one has its own limitation and constraints, which we shall discuss eventually. I have listed out few of the important sources of data here related to demography and health, which is, include Census of India, Civil Registration System data, NSS data, HMIS data, SRS, Demographic Health Survey, that is NFHS and DLHS data, and special surveys, particularly LASI and SAGE data. In the subsequent slide, as I said, I would discuss about each of these data sources from those three basic questions that I raised about, in terms of comprehensiveness of the data, quality of data, and accessibility of the data. Next slide, please. So first, coming to Census of India. Census, as we know, is the key data sources for us demographers, as it provides range of population, socioeconomic characteristics stratified by age and sex. The Indian censuses have conducted regularly since 1881, every 10 years without a fail. I think this is the first time that the 2021 census we will not be able to complete in time because of the pandemic, and all of us do know the reasons behind it. So that's the only exception that I can relate to. There is nothing else in the past that has deviated from the given year for the census. However, there are few concerns with the data quality of the census, especially with respect to its inability to collect information on mortality and morbidity. So coming to the quality of age reporting in 2011 census, that the figure that you see on the screen, age, as all of us know, is a critical stratifier in any research analysis that we do as social scientists. It is even more important when it comes to understanding of health status of a population, as morbidity and mortality both are highly subjected to age of the individual. We know that the risk of death and disease is highly variant with age. Thus, reporting of age data in census and so also in surveys is often biased as we see it due to digit preference or lack of knowledge. As you can see in the figure, which gives the single year population age from 2011 census separately for male and female and for rural and urban areas, starting from age 0, terminating at age 100 and above. You see spikes happening, and these spikes actually refer to the number of people reporting their age ending with 0 and 5, meaning that there is a strong preference for digits in India when it comes to reporting of one's age. And this happens regardless of area, state, socio-economic subgroup of the population, or even regardless of census year. You see it in the earlier censuses. You also see it in the most recent census. That one that I'm showing here is 2011 census, the most recent where the data is available for us. Next slide, please. The next issue in the census data relates to omission rate. The omission rates in Indian censuses actually have increased over time and are currently at 2.3% from 2011 census. Although the gender gap in omission rates have breached, they are substantially higher in urban areas, higher for rural females and urban males. They're higher for urban literate men and for separated never married men and separated divorced women compared to their counterparts. Next slide, please. Now, this is the figure. I'm simply giving the aggregate measures of index that evaluate quality of age-sex data in Indian census age. And what it tells us is that even in the 2011 census data that is currently available, age-sex data is of rough quality and it is only usable after some adjustments. And this is not a very encouraging sign, because if you look at 1951 census, our data quality was much more reliable. So next slide, please. Then the next important aspect is relating to release of data. Some amount of lag between data collection and data dissemination is understandable. However, with advancement in technology and knowledge, one expects reduced gap between data collection and dissemination. Data release for the Indian censuses has been delayed in the recent years. For example, religion and caste data of 1951 to 71 censuses was released within 2 years after the census, whereas it was released after 3 to 4 years for 1981, 1991, 2001, and 11 census age. Similarly, if you look at the language data release for 1951-61 census, it was released within 3 years, whereas for 1971-2011 censuses, it was released only after 5 to 7 years of the census. Some of us may know the migration data for 2011 census was released almost after a decade, just very recently. Next slide, please. Now coming to what is available in Indian census on mortality. Indian censuses have never collected data on death or mortality, ever. The only information that is available in Indian census is on number of children ever born and children surviving, which is collected from ever married women of the reproductive ages and from 1981 census onwards. One can indirectly estimate infant and child mortality levels using this data at national, state, and district level, as well as for population subgroups, including place of residence, that is urban, rural, male, female, caste, religion, education, and occupation of the mother. However, the quality of the data on children ever born and children surviving has always been a major challenge to all of us. It's not as good. It's not as reliable. I have used it from the 2001 and 2011 censuses for my paper, and it didn't help me much, to be very honest. Now coming to morbidity data, again, Indian censuses do not collect any data on morbidity either directly or indirectly. Nonetheless, they have been collecting information on physical disability, impairment, and mental illness very recently, and publish sex-specific data at national, district, as well as population subgroups. However, nothing is known about the quality of disability data in Indian censuses. In India, official disability prevalence rates are estimated at about 2%, very significantly, and it varies significantly across different data sources. For example, the NSS 58 round estimated 18.5 million persons with disability in 2001 in India, that compared with 21.9 million as estimated in 2000 census. This translates into a 20% difference in the prevalence of disability between these two sources. So again, the data, whatever little that we have, is a big issue related to quality of the data itself. Next slide, please. Now we move on to the next source, which is civil registration system, also known as vital registration system. And this is another important source of data on health. Next slide, please. The survey of causes of death was launched during early years, and during 1980s, it collected data on causes of death from 1,080 villages spread over 21 states and 3 union territories. In the interest of time, I'm skipping some of the points here. The SCD has been discontinued, as many of us may know, in 1997 at the national level. However, some states are still continuing. For example, Maharashtra still continues to collect information in SCD at the state and district level. In 1991, survey of causes of death was merged with the SRS, encompassing both rural and urban areas, and established a system to measure causes of death, known as Million Death Study, which used verbal autopsy to assign causes of death. Next slide, please. The indirect assessment of CRS data with respect to coverage level of death registration suggests that nationally, fewer than 70% of all age deaths and only 17% of infant deaths were registered under CRS in India during 2011-16. The source of the study is listed below. Further, more female deaths are missed than the male deaths. So there is a gender dimension to this under registration as well. Level of registration is extremely low in demographically lagging states, including Bihar, Madhya Pradesh, Rajasthan, and Uttar Pradesh, that I've highlighted in yellow, in red. I hope you can see that. Next slide, please. The number of deaths that have been registered under CRS has been improving over the years, which is good indication actually. However, if we see the progress in increase in medically certified deaths, which is shown in the blue shade here bottom that I'm indicating with my mouse, is extremely slow, and that's not a good sign. In 2019, only 1/5 of all registered deaths were medically certified, which is a very low coverage. Next slide, please. The share of medically certified deaths, as you can see in this figure across states, varies significantly, from a lowest of just 5% at the bottom in Bihar to 100% in Goa. And for national level, it is about 20% or so, 21%. What is equally more important here is that lagging states, which I just now mentioned, the bigger states, and they together comprise almost half of the country's total population. So even slower progress when it comes to coverage of medically certified deaths. Next slide, please. Yeah, so here I have shown the coverage of medically certified deaths in the districts of India. And what we see here that the districts which are shaded in dark red colors, mostly centering around our lagging states of Bihar, Uttar Pradesh, part of Madhya Pradesh, Rajasthan. That is where all these districts where the coverage of medically certified disease, most districts have less than 50% coverage. So that is a major concern, like any other health indicator that we talk about, whether it's infant mortality, whether it's child mortality, or any life expectancy, and so on and so forth. So there is a concern with these lagging states, and majority of the districts in these lagging states, if you can see in the table, for example, in Bihar, out of 37 districts have only less than 50% coverage of medically certified deaths. Similar situation you can see for other states like Jharkhand, Madhya Pradesh, and Uttar Pradesh. Majority districts are lagging substantially. Next slide, please. Now, I'll move on to the national sample survey data. So the NSSO has been undertaking nationwide household surveys in diverse fields, including socioeconomic health subjects. And NSSO has 4 divisions as listed in the slide. I'm skipping this part also in the interest of time. Anybody who wants to know about them can read it later. Yeah, next slide, please. So far there are 5 rounds from which health surveys are available as of now in NSSs, and they are listed in the slide here, which I'm not going to read out, but I would simply flag out here that the NSS only provides us information on third-party reporting of morbidity, and that too selected morbidity, not all, and hospitalization, and only at the state level, nothing below state level. Next slide, please. We move on to the HMIS. So as some of us may know, HMIS is a web-based information system that was developed during 11th five-year plan. It captures data online at the district and sub-district level on RCS service delivery indicators. The NHSRC conducts regular analysis of HMIS data and prepares selected statewide health indicators and publish them. However, lack of socio-economic variables in the data set makes the data less valuable for insight understanding. Next slide, please. Nonetheless, HMIS does provide information on age, sex specific deaths separately for public and private health facilities, for rural and urban areas, for India and state, on a regular basis, on monthly basis also as well. Infant deaths and the causes of infant deaths, including those related to neonatal and post-neonatal period. Deaths among children at ages 1 to 4 years and their causes, maternal deaths, all maternal deaths, and also the maternal deaths happening at health facilities, including causes of maternal death, adolescent and adult health deaths, including their causes of death, deaths due to major diseases like malaria, dengue, kala azar, and so on and so forth. And also it provides information on inpatient deaths in hospitals. Next slide, please. On morbidity, it gives information on prevalence of selected non-communicable diseases that are under National Vector-Borne Disease Control Program like malaria, kala azar, dengue, etc. Diseases among infants and children that include pneumonia, asthma, diarrhea, measles, tuberculosis, malaria, to name a few. There are many more that are available in the data sets. Maternal morbidity, that is during pregnancy, natal and postnatal period. Pregnant women with obstetric complications like antepartum, postpartum hemorrhage, sepsis, and eclampsia, and other diseases, who attended health facility for the complications. Next slide, please. Now we move on to sample registration system. So SRS was initiated in 1964-65 on a pilot basis and was later extended to full scale from 1969-70. I'll skip few of the points again in the interest of time, but highlight only a couple of points here on this slide. In 2014, SRS was operational in about 9,000 sampling units that were spread across all states and union territories of India, and it covered a total of 1.5 million households nationally and over 8 million population. The latest SRS indicators are available for the year 2018. Next slide, please. Now, nationally, about 81% of female deaths and 90% of male deaths are captured in the SRS that you can see on the top row here in the slide. Coverage varies across states, as you can see it here. However, coverage is lowest in Haryana and Rajasthan for female deaths, just at 70 to 72% of female deaths in SRS are registered in these two states from the recent data that is available. Next slide, please. Two of the most crucial demographic surveys, which I also mentioned earlier, are National Family Health Survey and District Level Household Survey. I would first briefly describe these surveys and list out the measures that are available on population health. So coming to the National Family Health Survey, next slide, please. Yeah. The NFHS, as many of us may know, is a multi-round large-scale household survey conducted in some representative sample units throughout India since early 90s. The survey has completed first 3 rounds at the state level. 4th and 5th rounds have been completed at the district level. Each round collects data on health and family welfare indicators. Number of domains are covered, which I'm not going to read out. But in the context of our theme that we are addressing today, just to flag out that NFHS provide information on at the state and national level on infant and child mortality and perinatal mortality in recent rounds, prevalence of tuberculosis, malaria, and few selected non-communicable diseases like diabetes, blood pressure, hypertension, etc. In the recent rounds. And for mortality, it collects deaths in the households during the reference period, which is usually 3 to 5 years prior to the survey, along with their age and sex of each of the diseased person. So this is the information available on fertility and on mortality and morbidity in the NFHS. Similarly, in DLHS, it has completed 4 rounds and provides data at the district level for the healthcare utilization indicators. On mortality, it provides information on all deaths that occur in the household during the reference period, again 3 to 5 years prior to the survey, along with age and sex of the disease, similar to the NFHS. Next slide, please. Yeah. So if we summarize the indicators that are available across SRS, NFHS, and DLHS, they usually would provide information on CDR, ASDR, IMR, U5MR, 1 to 4MR, and usually for rural, urban, male, female, for India and bigger states. In case of NFHS and DLHS, they are also available for population subgroups, particularly if I remember by urban, rural, male, female, and education, wealth quintile, etc. For smaller states, they only provide crude death rate and IMR. Prevalence of selected morbidity is available in NFHS and DLHS, but not in SRS. Next slide, please. So the next down, please. Yeah. So then there are other surveys, as Professor Kulkarni also mentioned, which are focusing on subpopulation subgroups, especially for elderly or adult population, which is longitudinal adult survey in India, LASI, covering 45 years and older population, and a study on global aging and adult health, SAGE, that covers 60 plus population. They do provide information on morbidity, self-reported, as well as measured, and mortality for this population subgroups in both these surveys at national level as well as at state level. However, as I recall, the sample size is too small in these studies to give us understanding on age-specific mortality scenarios. Next slide, please. So, next slide, please. So coming to the data gaps. So data on basic mortality indicators, as we have seen, is unavailable for smaller geographies, socio-demographic population subgroups. Cause-specific mortality, causes of death data, is extremely limited. And I would say even at the national level, I don't think we have good understanding of cause of death pattern in this country, segregated by gender, by age groups, by other social demographic characteristics. Morbidity data again is extremely limited, and whatever is available from disease surveillance is very scantily, and as I see, is less accessible to the researchers. Unlike our NFHS and DLHS type of data, which are freely available and accessible to anybody for any scrutiny, analysis, examination. Currently, registration level of deaths are poorer at 20 to 50% in several states with larger populations. Only 6 states in India have 100% death registrations. Access to unit level data, except for NFHS, DLHS, LASI, and SAGE, is a major challenge for most of us. Next slide, please. So what is way forward? I would say that there is a need to strengthen official data system, and we need to invest more in our civil registration system, HMIS, and sample registration system. I would rather suggest that government should try to expand SRS to ensure that it is able to capture district level scenario, and if not morbidity at district level, at least mortality. It should also try to, I think, capture causes of death data, particularly under MDS. I would say for state level. Currently, it is very, very limited. You should see the tables that is published on the RGI site. They are only for EAGA or non-EAGA state, or group for the bigger, only for few bigger states, and all smaller states clubbed into a big category. So they are not really going to give us much insight in terms of what is the pattern, how things are changing, unless and until we have an understanding on epidemiological transition of this population at the local level. It is very difficult to plan programs and strategies to improve the scenario in future. So it's very important that we spend resources. And when I say resources, it is just not talking about money, but also into the manpower to strengthen these systems, because I see over time the human resources are weakening in this system actually rather than increasing. And then second important point that I would want to mention here is that we must have a comprehensive monitoring and evaluation system in order to monitor progress towards achieving the universal healthcare coverage and sustainable development goals. Not only at the national level, but I would recommend at the state and district level, if not below that. Similar to the large-scale demographic health survey that we have discussed, whether it is NFHS, DLHS, LASI, SAGE, or SRS, we must plan surveys at regular interval to capture morbidity, at least for most common or fatal diseases, if not all. At the same time, we must avoid duplication and cost of additional surveys unless absolutely necessary. Wherever possible, it is useful to expand the scope of existing surveys to capture information for smaller geographies, population subgroups, if not every time, maybe on a rotational basis. That could help us fill in the gap. Data dissemination and its usage need to be strengthened. We are, I think, too data shy in this country. First, we don't demand for the data. If at all, whatever data is available with us, I think we are satisfied with that and say, oh, at least I have got this now to work with. No, that shouldn't happen. We need to demand more and more on data on health and demography in this country and at the lower levels for population subgroups. And that only would probably awaken the system, and that they would think about expanding these resources for us in future. And last point that I would want to make is that whatever data set that we try to generate, whether it is system data or otherwise, we must include basic stratifiers for disaggregation of data, which can give us insights to understand the dynamics, understand the local conditions, and also examine inequalities in health conditions of different population subgroups in order to come up with local and need-based strategies for upliftment of the health of the population. Thank you very much. Next slide, please. For your attention, your question, comments, and suggestions are welcome. And thank you once again. I hope I didn't take more time than what I was given.
No, thank you, Usha. It has been very comprehensive coverage of various aspects of demographic and health data from someone who has really been using the data extensively for research. And actually, it is the researchers who make greater demands on the data. As Usha just mentioned, we must demand data. The researchers go on making demands of the data. And that is a good thing because that pushes people to provide data, which some of it we have been successful, but of course not always. In certain aspects, I don't want to get into the specifics, we have not been successful. But some things like NFHS and so on, we have been successful in getting this data. And now gradually that has led to certain others. So thank you very much. We'll ask the panelist, Dr. Rattan Chand, first, please.
Okay. I'm happy to see you, Professor Kulkarni, Professor Usha Ram, and also to listen to you. You have very nicely given the introduction. And I also happy to interact or share the this thing, my experience with my co-experts and viewers. So Professor Usha Ram, I think she has very nicely covered the aspects of health data. It's an excellent presentation, and she has very nicely brought out the way forward and the issues. So I'm very happy to see that. So it is that she has rightly pointed out that the lack of health data on diseases. I have also been experiencing while working in the Ministry of Health that we have good data so far as family welfare or reproductive child health is concerned, but the data on the diseases, especially all these vector-borne diseases, leprosy, blindness, etc., it's very limited data. And even if you have some data that is published in the National Health Profile, I think that is quite a underreported data, because those whatever is reported, that's not a complete that is not complete data. That is a very, I think, scanty data. So far as the this surveys are concerned on the health aspects, I think only survey which is nationwide or representative, those are the national NSSO surveys, which are covering some morbidity profile and also the expenditure on health by the households. So that is the only thing in my view. It has also been pointed out about the time lag in bringing out the data. So I think all of us, we fail to understand that when we have the latest computing technologies, why there is so much delay in delays in increasing instead of it is being reduced. So that is an issue, I think, to be considered. Maybe I think due to design of the format or other things, because of which we are not able to analyze the data timely. And data accessibility is another issue she has raised. I have seen in the ministry, NFHS data was available, DLHS, data from surveys was available. Later, NSSO also started giving data. And you being a researcher, you must have experienced that NSSO data was not that user friendly. But with the experience of NFHS, DLHS, they have also, I think, now improved, and their data is also now more user friendly. In the case of health management information system, today I was seeing earlier we used to give standard reports which were almost concurrent. You can print out the report up to the latest week. If you're on 23rd, you can print the report up to 20th of this September. So, but now today I saw this data is available. Those reports were available only for 2019-20. With the passage of time, what have made them to remove those reports or stop producing those reports? They should have improved. And the system has been made more open to the public. That's what I heard. And another important issue is the inconsistency of data. Often, I think working in the ministry, and you might also have seen working in your research work, for the same indicator, for the same period, you will get different data. For example, if I see the number of, say, primary health centers, so in the same document, you can find different number of primary health centers. And definitely in the different publication, you will find different numbers. So this is one example I'm giving. There are many examples like this. Another aspect she has raised completeness of data. So completeness is if we see take the example of health management information system. If there are, say, 2 lakh facilities which are supposed to report every month, and out of those 2 lakhs, sometimes 1,70,000, sometimes 1,50,000. Suppose they are reporting like that, but we are taking total of that without finding that how many are reporting or how many are not reporting. So another issue is, even if the facilities are reporting data, so we have, say, 150 data elements. So all the facilities, even if those, for some of the facilities, those data element may not be applicable, but even for those for which these are applicable, they are not reporting on all the data elements. So this is also a problem, and we get the total and use that whether some facilities have reported that data or some has not reported that data. And other thing is about the surveys is, I will say, the poor monitoring of the surveys. So what I used to say while in the ministry, suppose there is a decline in the fertility or mortality. It could be due to the fact that the field workers, they have not captured all the deaths or all the births. If they're not capturing all the births and deaths in the field, then naturally your estimate of fertility and mortality will be low. So these are not due to the program efforts that fertility has come down or mortality has come down. It is because of the poor execution of the field work and poor monitoring of the field work. So that is also one of the important. And another issue she has highlighted in this data for the smaller geographies, for the smaller states and the union territories. Often, I think we have been facing this difficulty. We don't find data for these smaller states and union territories. And these states and UTs are also upset that why the government of India or others, they are not giving data for us, and when other states have this data. So something has to be done for this. She has raised these issues. Now, I think with the NFHS, the data is available up to district level. I don't know whether NFHS, because the cost goes high, sample size goes high. If it is possible, they can bring, they can give estimates up to the block level, but I think feasibility has to be seen. whether that can be done or not. But for the HMIS, it can be easily given up to the block level or even up to the primary health center level. So that is possible because that is only the computer computing and all the facilities they are linked to some primary health centers or the community health centers. So, and so far as duplication is concerned, I think in the field of surveys, NFHS has done a good job. Earlier, we used to have these district level household surveys, annual health surveys, and then also the National Family Health Survey. So what we thought, all of us, we thought together, IIPS ministry, that why to have so many surveys? Let us do one good survey to provide estimate up to the district level. So this has taken place. This is a nice, I think, improvement. So far as Madam, your presentation is concerned, I think on each of your presentation, we can discuss a lot, but within the given time, these were some of the points I wanted to highlight. Thank you very much.
Thank you, Dr. Rattan Chand. Actually, as you know, Dr. Rattan Chand is an insider in the sense he has been with the ministry and where the data often are produced, used for a long time. He knows how the data are produced, and he has also been a user as a researcher, and his comments are very valuable. May I request Dr. Bakshi now?
Thank you, Arjun. Am I audible, Arjun?
Yes.
Yes, ma'am. Please go ahead.
Thank you. First of all, I should thank Professor Purushottam, Professor Usha Ram, and Dr. Rattan Chand for giving these insightful presentations. And I don't know if Dr. Rattan Chand remembers, but sir, I was actually coming out to you in 2013 and 14 on USAID project when we were doing the National RMNCHA unit we had established, and we had actually RMNCHA strategy, which was encompassing all the interventions based on reproductive, maternal, newborn, child, and adolescent health. And you were the one who had actually created the composite indicator for all the high priority districts, 184 high priority districts. And based on that, so I have been monitoring and going to all the different states. I used to travel almost 10 to 20 days in a month to monitor high priority districts. So I won't be sort of today talking about the data because you're the doyen of data here. So what I'll be talking about is my field experiences, because I have almost 10, 11 years of field experience across the high priority districts on RMNCHA and HIV/AIDS. To begin with, I will be speaking more on the importance of data and monitoring in decision making. So when we see what I am sharing my own experiences, when we used to capture the data against the 5x5 matrix, that was actually we had to monitor the data at the block level. We used to go from Government of India and monitor the states, 184 high priority districts. And the monitoring was actually, the main purpose was learning and improving. It was based on providing accountability of the resourcing, checking the drugs, making informed decisions based on the program. But there have been a lot of discrepancies, I should say, as Dr. Rattan Chand already said, and as Madam Professor Usha Ram also pointed out, two things which I felt throughout, one is localization, and second is disaggregation of data. Even if we used to look at the NM registers, if you will look at even in NFHS 4 or NFHS 5, we see the kind of nothing has changed. If you go to Nagaland, still the immunization ranges between 30 to 40%. I always find to understand why there is such a kind of gap, irrespective of having all the e-bins and other kind of immunization parameters, and so much of monitoring happening and so much of data analysis happening. Still we have not been able to reach the above 40% immunization. And second question is, when we go across different states and all that, there has been so much of disparity. It is not disparity at the state level, it is disparity at the block level, it's disparity at the district level. You will find like very different indicators in Kerala and very different indicators in like, UP or Assam, mortality rates going high. Second, madam, this Usha Ram also spoke about the mortality and morbidity. Coming back to it, ma'am, I know like when we had to review the MDR, maternal death review reports, most of the reports used to come like 33%, it was always showing like others. And what this others meant? Others was, they used to say, these are anemic related deaths. But others was a huge chunk, almost 33%, and it still continues. So my question is like, if these others, if we have not been, irrespective of having the National Anemia Control Program, still we are like, dangling between having the pregnant women or women in general, like between 50 to 55% across India anemic, then how is data going to influence, or how is data going to influence the policy, and how we are going to have the evidential planning? And to be frank enough, ma'am, I also feel, ma'am, that every sixth human being belongs to India. And it's very important that India must achieve the SDG target of SDG 3. And we all completely agree that if we have to, India is actually the key indicator to determine success or failure of SDG, given this its disproportionate share in global burden. That is one thing. Second, I see there is a huge social disparity. It's not just the social, it's the economic disparity. I will share with you, ma'am, some of the incidents. I mean, we are talking about data. I mean, I can today reflect, like, even though 102, 108 is across, when we are talking about the ambulance, it's across India. But I still can see, like, I was on a health mission to Orissa and I was monitoring, and I was in Kalahandi. And in front of my eyes, a woman, she grasped and she died. She had just 2-year-old baby with her husband. Her father and father-in-law were there. And this lady was just 21-year-old. And why she grasped? Just 5 minutes down the lane, we just walked down the lane. We saw 102 lying there. And after some time, we saw 108 also ambulance lying there. What was the cause? The cause was that even though her husband had tried to reach out to 102, the ambulance could not get sort of listen to them, maybe because of the, telephonic issues, or maybe they didn't have the lines. I'm talking about 2017, 18 months. Same way, like sometime back, I went to Dindori, and in Dindori, I don't know whether they are jammers or whatever is there. People are not able to connect. Today, we may say that we are like, we have enabled the internet and everything, and we have the data in places and all that. But these are the implementation challenges. We are saying that ASHA has to do 40, 50 kind of like, services. She has to give it to the beneficiaries. But if we'll take example of our topography in Barmer, or Jaisalmer, where in one toli is at one place and second toli, by toli I mean say houses, hamlets, they are at one place, and at another place there is another hamlet, wherein Asha may have to travel almost 10 kilometers to go from one place to another place. So these are the topographic challenges that we have to look into. But at the same time, I'm quite hopeful, because I completely see that the way Prime Minister has given the slogan, Sabka Saath, Sabka Vishwas, Sabka Saath, and Sabka Prayas. So these are some of the things that we have to look into. But at the same time, madam, I would suggest, like, along with data, we need to look into, along with what you said, rightly said, localization. How, because central cannot do everything. Health is a state subject. How we can percolate it down to the village level. That is what we had envisioned. That is what we had thought. That is when PIP happens, and we think that when we budget, it should come from bottom down approach to bottom up. It should come from the village, from the simple ASHA to the upside. But mostly that is not seen. It is the states like who, at the end of the, even though the requirement comes, whatever is, it's the state's prerogative. Second thing, ma'am, you spoke about, which I feel is very, very much pertinent, is the quality of data. I don't think that I have come across any time like some kind of perfection wherein you can say that this quality is perfect or something of that sort. So we need to look into that also, madam. And to begin with, I don't know, ma'am, I would like to share one kind of major disparity that I see. I mean, there are some of the segments, some of the populations, like sometime back I was traveling in Bihar, Eastern Bihar. If you are familiar with there is a Musahir community. Musahir is Musa is rat. So they call it rat. Either they are the rat killers or they are the rat eaters. And
Musahar is the community.
Yes,
that's
yes,
right.
yes. Yeah. So what I'm saying, ma'am, I mean, if you see still, ma'am, those kind of challenges are there. And Musahar is, I mean, it's not a small, they are almost like 3 million in numbers. And if you look at their literacy rate, it is just 9%. Aaj ki date, ma'am, there was an Oxfam report, I think it was in 2018 Oxfam report, and they had identified and they had spoken about these vulnerable groups and vulnerable communities. So I think that these are also some of the issues, like if data, what you rightly said, that we need to localize the things and we need to disintegrate and we need to go deeper into the roots. I think that is a big challenge now. So I will put a stop here because we have another person. He also has to speak. I would have loved to continue because this subject is very, very much favorite to me, especially the public health. Maybe some other time. I will share some more community practices.
Sir, it has somehow got muted. Kulkarni, sir, in your phone. Yeah.
Wait a minute. Yes. Now
Yes.
it's okay.
Got
All
it.
right. I think I muted instead of unmuting. Thank you. Thank you, Dr. Bakshi, for your comments. This brought in basically the policy aspects and the basic humanitarian aspects of the data, how data are used and how they're required. It is not just dry statistics and so on, but actually what is the need for the people and for policymakers. Thank you very much. I have requested Dr. Srinivas Goli. Dr. Srinivas Goli is a bright young researcher analyzing data extensively, and not just Indian data across various countries. So we should hear from him. Dr. Goli, please.
Yeah.
Srinivas, please.
Yeah. Thank you. Thank you, sir. Yeah. Thank you, Arjun, for giving this opportunity, and also once again listening to my teachers. So it's just, of course, I have nothing to say in front of my teachers, but okay. But given that, like, I'm also like going through some of the data set these days, even including not only the survey data sets, but also the official data sets, administrative statistics, vital statistics of not only India, but also some of the developed countries. So just I want to just highlight just a few points. I don't want to take much time, as already we spent a lot of time. Just I want to highlight a few issues, maybe I think just for audience sake and for public debate and all. One is of course, Professor Usha Ram has really nicely highlighted and given a big overview of the existing data sources and the problems related to it, and of course, how we can like wisely go ahead, like to improve the quality of and the efficiency of these data sources. So here I just want to highlight just a couple of areas. One is like data quality of analysis is really important, but what are the strategies? Just I want to highlight one or two things here. Like for example, death registration and birth registration. So in order to see the completeness of death and birth registration, we have a lot of indirect methodologies to assess this completeness. But we can also, like, if we are like willing to include a few questions in the national surveys like NFHS, we have one question this time, like, the birth registration, about the birth registration, but just apart from the birth registration, even one more question about the death registration, and also asking the reason, if in case they have not registered, then asking the reason why they have not registered, then that will give us, what are the reasons behind, like, people. For example, if death registration, if there is no proper, once Kulkarni sir only told this to me when I was discussing with him, see, there are like death registration, there is a purpose for death registration, because they need, like, there is a property dispute or any kind of other kind of issues, then they need a death a pension, for example, uptaking of pension, transferring of pension from husband to wife, or for these kind of issues, then they need the death registration certificate. So unless there is kind of a necessity, they are not going and registering a death. So if you find the reason why they have not registered a birth, why they have not registered a death, so that gives you a lot of clues to where to work and how to improve the registration in the vital statistics. But personally, of course, I love to use the surveys, but I am for for a long term, because surveys is not a permanent solution. This is a temporary, in filling the gap when there is no quality official data sources or vital registration data sources. We are using them as in a form of a complementary or supplementary to what to the vital registration. So therefore, ultimately, we need to improve our vital registration system, because we can't continue to use these surveys for long, because we need to somehow get our data, quality to the developed country, so that there will be always an inter-country comparison. And also the developed countries, for example, today, if COVID data you look at, if we talk to any developed country scientists, they say just, okay, we don't know what kind of data coming from India. There is less faith in Indian data. So therefore, that we need to increase the faith of the, faith in our data systems, for the people across the world. So therefore, I personally, for enhancing the vital registration system, MCCD, and HIMS. Of course, HIMS is, I am the one of the really I like so much the HMS data. Recently, we have started working on it. Of course, there are problems, but there are really some things which from HMS it is coming out to be really useful. So therefore, the strategies how we can evaluate the data, not only the indirect methodologies, but also through the direct methodologies, of post kind of, in the HMS, PRC is now doing kind of a post enumeration surveys, particularly selecting certain blocks and districts, then doing a survey and comparing it to the registered data. So that kind of evolutions, of course, they can help us to understand where we are going wrong in terms of generating a good quality data. Then how to use the existing data and and also a kind of a convergence in the data sources, a convergence and making data sources complementary to each other. That is also very important these days. For example, if you look at the NFHS 5, NFHS 4 just conducted 2 years back. The data has just come out, and then immediately we had NFHS 5. There are a lot of birth histories overlapping, but then when you don't have much time between the two waves, then there tend to be, if you compare the figures from NFHS 4 to NFHS 5, there will be a lot of discrepancies. That's what happened in many indicators now. And the people who don't understand a lot of technicalities of this, how the data has been generated, how the figures has been estimated, then they started debating so many ways that they're debating the issues. So that kind of things is very, very important. And also timing of the surveys. Of course, invest, but invest smartly. Invest more, but invest smartly. And then, for example, if you take the NFHS again, see, NFHS is really more useful and efficient when it comes between the census, and also in between the census 2 times, you can say that every 5 years. Okay, so therefore, the timing of different national surveys, particularly those are big surveys, is very important to at least to show the complementarity between surveys, and also understand the and also comparability, but both complementarity. Even that same thing applies with the SRS. And another thing, the sharing of the unit level data for assessing the quality of the surveys. See, census, of course, when Professor Kulkarni was there at JNU, of course, he is the one who helped a lot to, setting up the census data centers, and then somehow it was promised to give the 5% of the overall 5% of the census data. if that could have been done, it would have been helpful a lot in assessing the, not only estimating the rate ratios, but it also to help you understand the data itself. So in terms of both coverage and content errors. So that somehow is not happened. And I personally feel even SRS has to give the unit level data outside to assess the quality of the SRS data, because though it is the gold standard, no doubt, it's a dual registration system, no doubt, but still today we are getting certain issues. For example, I recently estimated something, MMR, maternal mortality rate, and for Punjab, the maternal mortality rate is rising. Of course, it's like, and also if you take the sex ratio estimates, the discrepancy between sex ratio estimate of SRS to NFHS census. So therefore, what I see is that, giving this kind of data, of unit level data, of course, sharing, it's up to the governments to whether to share or not to share this data. But if, as a researcher, if you ask us to how to improve these data sources, and please be open to it, like put it in a public domain, put it for public scrutiny. Therefore, you get more solution to it, multiple solution to understand the data sources. Then also there is there is a lot of residues, and also the hesitancies existing about the surveys and also census and other things. Suppose if you go to the village and ask about something, so they always are in the panic, like what to report and what to not report. Even if it's reporting, suppose if it is the income data or if it is any other kind of data, so it's a lot of kind of a pessimistic thinking around it. So therefore, what I see is they're kind of a mission, like we are running missions for many other things, like it's the polio, it's a many other things. So why can't one mission come out for the data awareness, like in terms of reporting death, in terms of reporting birth, in terms of reporting marriages, So I think it needs to be taken as a mission, a big mission to launch it nationwide and put an awareness campaign across the villages, the states where, of course, I personally feel it should be a nationwide campaign. And see, for example, MCCT data. One example I give, everyone, of course, when I started first working on using MCCT data, I started working on this epidemiological transition in urban Maharashtra. Wherever I send the paper, immediately the comment comes, oh, this data, there is a quality issue. But one has to observe that particularly in case of urban Maharashtra, there is a World Bank program. It has been extensively, people got trained, and also there is a workshop worked around it. And therefore, the urban Maharashtra MCCT data quality is much, much better than, it's a 76, 78%. It's way high than 38% or 35% of overall Maharashtra. So therefore, when, like as a researchers also, we need to build the confidence in data coming from certain pockets and see, can we replicate that same process to other areas? So therefore, what I feel is also we need to build the confidence. Even when I recently worked on HMS data, using HM, we are estimating something. Of course, some reviewers is fine, but some reviewers still again started telling, okay, why can't you estimate a point? You just estimated the point estimate, why there is not a confidence interval. This is a census. Why we need confidence interval for any census registration data? Okay. So therefore, there is these kind of residues also you need to remove. Build confidence in the data process, build confidence in the data registration, build confidence in the data reporting. Then only, I think these together, we can build a strong data systems in a country. Then last one is, of course, about the digital health thing. When this was announced, I wrote a media piece on this. See, the digital health has been very successful in a country. For example, now I'm in Australia. Digital health is one of very successful system in Australia, because in Australia, the majority of the hospitals or majority of the health system is the public. The public, 60% is public and 40% is private. And even private works within the overall supervision of the public. And and with a huge healthcare expenditure. Okay, so public health expenditure. So therefore, what I see is like, without this, if you bring a system like digital health system, when in what happened in Ayushman Bharat, when you trying to empanel hospital, when you are inviting private hospital to come and be part of Ayushman Bharat, how many hospitals are coming forward? There is a lot of hesitancy from the private hospital to come on board with the Ayushman Bharat mission. So therefore, whether these private hospitals come on board when there is not a private profit involved in for them, or there is no beneficial factor for them. So therefore, what I see is like, of course, if it works, it's one of the best thing which can happen in a country like India. But how good it can work, if it has to work, then what one can be do to how we can deal with 66% of private hospital dependency in India. So how that data and what kind of quality, how you assess the data coming from the private hospitals is also very important. I think there are some other things, but I don't want to take time. There was this last one is like, so far we are debating quality about rate and ratios. We are at still rate and ratios, but the world is looking for how to establish a good causation. So we have started some special surveys with a longitudinal approach, but still we need more and more longitudinal surveys, life history follow-ups to establish a causation, to understand the factors behind, changing morbidity, changing mortalities, changing fertility behaviors. So therefore, of course, our first mission is to establish at least a representative estimate, and then we have to go for how good we can generate a causal, a data which can give causal, where we can analyze the causal relationship. Sorry, and there is a lot of sound. And also using the rare data sources. See, someone to talk about the ambulance and other things I just taken. See, I just happened to look at the GVK data of 108 in Andhra Pradesh. There is a huge data from the GVK on, the patient referrals, health issues, and then causes and mortality and all. So if these kind of people, we are investing a lot of money in running these things, why can't you use that data and give it for open access for the public to analyze those data? Okay, it's a huge data. Even for Andhra Pradesh, the sample was very, very high. So therefore, using the rare data sources is also one source to understand morbidity and mortality causes. So thank you so much. Sorry, it is.
Thank you. Thank you, Dr. Goli. Very useful, because you have really been working on different kinds of data, not just survey and so on, but other things. So these insights really add to it. Before we open this floor, Usha, would you like to make some quick remarks or respond to some queries, or should we open it?
I think we can open it, because I can probably combine it at the time when others are asking questions, because I have noted down all the questions and suggestions, obviously.
All right. Okay. So now, who is raising the hand?
No one, sir. I think everyone asking questions.
I don't see anybody raising hand.
Sir, there are some questions in the chat box.
The question to the chat box is Nikhilesh Kumar, which you have answered. Arun Sharma, any delays due to lack of efficiency? I think Professor Fauzdar Ram, if you would like to answer his question. Are we moving towards democratization of demographic and health data?
Yeah.
I mean, it's a very big question I can answer, but I don't think I would want to answer it on this forum, because there is obviously a very different perspective to these issues internally and may cause concern individually to me. But I would say a few things, obviously. Yeah, I
Okay.
think we are certainly moving towards democratization of the data. If you honestly ask me, if I compare it with the previous times, for example, when we were students, say 30 years ago, accessing NSSO data, even on the payment basis, was complex, was difficult. But
There is
today, it is relatively easier. And information is being collected under different systems, whether it is HMIS, whether it is CRS, whether it is SRS. Although the unit level data is not accessible, but data is coming out in public, I would say, for use, which was not there earlier. Now, there is a filter, obviously, as all of us would know. And I don't think I would want to go into those details. But as far as I see, certainly it is happening. And yeah, and we must link our data to human rights, because human rights start right from the birth. And the very first right is the registration of birth itself, which is violated. Right? And should end with the death registration, which is again violated in many cases, I pointed out. Infant deaths, only 17% we are registering. So certainly we need to give that perspective to our system, and then say that there is a need to strengthen these data sets to ensure that we award our constitutional commitments of basic human rights. I think that's all I would want to say here.
Yeah, okay. Oh, there are some questions. Unit level data from census. Well, actually, no, 5% were available, but I think Dr.
No.
Srinivas Goli has already mentioned that. That
is only for household amenities. They released 5% data, and that too from 2001 census only. After
that
that,
initiative
nothing.
has not been successful, unfortunately.
Absolutely
It was
not,
initiative by the census office, but it has been successful. Do people have right to know basic demographic data at the level, local level? Well, census data, primary census abstract is available at the village level, but it gives certain things. It does not give distribution by religion. It does not give detailed age distribution. And there is a reason for that, because according to Census Act, some of this information, which would indirectly lead to identification of the persons, is not to be given. So Census Act protects it. So certain information.
I want to say something here, sir.
Yes. Yes.
You know, we always have this evasive approaches to our justifications, where we say, because of this act, I don't make this data available. If honestly you want, I can identify PSU from NFHS. I can do certain commands and then do that. Let me be very honest with technology. So that should not stop us from sharing the data. And
but that is
you know,
that is the reason why
you are not disclosing the individual's name, sir, isn't it? In any case, you are not disclosing. All you would know, probably, let us say the domestic violence is more in village X. Doesn't make everyone a criminal in the village. But then by disclosing this, we at least know that there is a problem in this village and need to be fixed. So I think we need to take that approach, as I look at it, honestly.
There is another question.
Census should do the same thing.
I don't know whether who can answer this. Why not create basic nursing course so as to place these persons in every hamlet village? Well, you already have Ashas, but they do not have not necessarily basic nursing course. That's the only thing. I don't know whether
they have been trained into these systems and data collections and reporting.
Rana, so I think Rana has a question.
Yes, and sir, Rana ji has also joined. Can you?
Yeah, thank you.
Please go ahead.
Can you please answer?
Thank you, sir.
Ask your question.
Am I audible?
Yes.
Hello.
Yes, please.
Yes, okay. We can hear you.
Yeah, thank you so much. This is an interesting session. I was waiting for this session, and this was very interesting to me. And a lot of things is covered already. And I have two specific question about HMIS data. One is there is always fear that HMIS data is a service statistics, and that may be over-reported. And this logic, this thought is applicable to all service statistics. And what are the mechanism of ensuring the data quality of our reporting issues? Of course, PRC is conducting conducting some primary survey to check it out, whether it is overreported or not. And second thing is about coverage. Second question is about coverage, because we know that 2/3 of India's population access health services from private health facilities, and whether these private health facilities are covered in NFH, HMIS. So please, if I am wrong, please correct me. And
Okay,
of course,
I think, yeah.
Of course, yeah.
Yeah, I think that
So
can be.
Could we
you have
incorporate?
Okay, you can keep it in mind. Maybe at the end we can respond. Or would
So
you like
should
to
I respond?
respond?
Yes, sir.
Yeah, you go ahead. If you can
Yeah.
immediately respond, fine.
So just taking your second question first, whether the HMIS provide information from public health facilities. As I said in my presentation, the deaths and causes of deaths that are stratified, the death by age are given separately for private facilities and public health facilities. Causes of death are not stratified by type of facility. So in HMIS, you do have that classification for number of deaths only and number of morbidity conditions, etc. Then coming to over-reporting in the system, whether it is system-generated data, whether it is service-generated data, there is always some amount of bias, whether you call it over-reporting or whether you call it misreporting, right? For example, age, as I said earlier, or non-disclosure of sensitive information, for example, due to the social stigma and all that. For such things, all you can do is to create knowledge and awareness among individuals who are responsible to collect this information, to ensure that they collect it as appropriate as possible and strengthen your monitoring system. That is all you can do. You can never control what respondent report you unless and until you are intelligent enough to capture it accurately, because you ask a question to respondent or to a system, they would report you what is asked, what they understand. Now, as a data collector, you need to take care of it to ensure that you are getting the right information. And for that, as we do in our surveys, for example, NFHS, we have very intensive training to our investigators and data collectors, which I think is not as extensive in the systems that I'm familiar with, whether it's NSSO, whether it is SRS or the system generated data. So I think you need to strengthen both training and monitoring system to ensure the good quality data and avoid over-reporting.
I see one question. Nihira? No, she's not here. Nihira, R. Nihira.
Sir, I can read it out, the question.
Okay.
Very quick. Data is important for identifying the conditions of marginalized sections of society, but how it can be ensured on a grassroots level that accurate data is provided from government sources, and more importantly, who can be held accountable when those procedures fail. And the next question is on, are there data on pregnancies and maternal health? There is, I guess. Would you like to take this question that
I think, yeah.
accountable when there is such data discrepancies? HMIS comes with data for every month, so there is also so much of haste to report the data. What do you see regarding that? The quality is up for the real time.
So, should I respond?
Yes, ma'am, if you want to, or the panelists can also.
Yeah, anyone else, because I'm sure Dr. Rattan Chand can answer, Professor Kulkarni and Goli both can answer, I'm sure. So,
right,
yeah.
right. Professor Kulkarni, yes, we can also take
Well, this is a question on all data. How can you ensure accurate data is provided from government sources? If government collects accurate data, then the accurate data can be provided. If the data themselves are not accurate, they have gaps, obviously we won't get this, and this happens very often, especially for morbidity and so on. This is very common, and we just have to live with it until the procedures improve. Basically, what we require is as perfect collection of data as possible. The next stage comes in release of the data, tabulation and release of the data. But first we must have that, which is not happening for civil registration, as Dr. Usha mentioned. Civil registration itself, we have problems. Infant deaths are not recorded. And this is something that is unfortunately the case for certain things. Overall, reporting of births has improved, but of deaths, it is still far from satisfactory, especially in some areas. And the same thing is true for morbidity as well. Yes, pregnancies data, they are there. NFHS does ask data on pregnancies. It is
Yes.
because in fact they also give number of persons currently pregnant and so on. So those data, some of these data are there. We may not get some of these things in the fact sheets. One has to go through the data because they have large number of variables, and one has to then extract from it. It was some of doing, but as it was mentioned, these data are very friendly. As I think, if I'm not wrong, Dr. Rattan Chand mentioned, the NFHS data are very friendly now, and it doesn't require that much effort as it used to in the past to get data. One has to, of course, spend time.
Yes, sir. This pregnancy calendar data is also it's a bit difficult to, unless a trained person, it is difficult to handle the data, but there is enough data is there about.
Absolutely.
Don't expect IIPS to give everything on the plate. Users also have to work a bit, but I think the NFHS data are very, very user friendly compared to data sets in the past, and there is great amount of transparency in the data. That is a fact. Everything is crystal clear.
Sir, regarding this marginalized question by Nehru, sir, there is two things actually with comes, because we did a sub-caste level survey, because there is a lot of challenge whether we can collect the caste level data or not, like particularly biradari level data we could call. So it is like census, when we are including that particular question, there is a lot of debate. So previous when the Congress something disturbance. When the Congress government asked that to whether we can, because when the Jats and other Marathas, Kapus demanding the reservation, they asked us to collect this data and analyze this data. So what we understood from that is for a marginal, I think lot of disturbance. I think maybe it's okay. Sir, there is a lot of disturbance, I think, coming out from outside. Okay, so what I say is when we try to collect this data, what we observed from especially from the marginal section side is there are two kind of errors for the marginal, particularly the data coming from the marginal. One is of course, they are like the way they are excluded in many programs. In the data process also, in certain section there is excluded because the process is particularly existing Indian caste hierarchical system, that is really possible. What we observed from the that. Another is from themselves, they are not empowered enough to report their own information correctly. That is also we have observed. There's two-way process. They have excluded from the data process, and also they themselves not empowered to report from their data. So this is what
Thank you. I think we have run out of time, literally, the time that was allotted to me in the sense as a chairman. So I take the liberty from the organizers of a few more minutes of
please go ahead.
minutes. Professor Usha Ram would like to make some final comments.
Yeah. I think the points that are made by all the three discussants, and I have noted down, I wouldn't want to go over them one by one, but to just say a few things about some of the important aspects which have been repeatedly raised by all the three discussants, I would say. First, I think we all agree that there is a very strong need in this country to invest more into data, health data, especially within the system. I totally agree with what Goli says and others say, that surveys are there, but they must not be a substitute to system data, because they can never be. Having said that, I also think that it is very important for us to ensure that our system data also make conscious efforts to bring in socio-economic, demographic identifiers in their data set, so that their value enhances substantially to understand or to gain insights of localized issue. That is first thing I think I would like to reiterate based on the discussion with what everyone said. Second thing, I think we also need to understand and lay a lot of emphasis on demanding data. Unless and until we demand, कुछ नहीं मिलता है. माँ भी दूध नहीं पिलाती, जब बच्चा रोना चालू करेगा तभी दूध पिलाती. All of us know that, right? And therefore, as a researcher, as a social scientist, we must demand data from the system, from the government, as and when we need, and even if we don't need. And I will tell you this, that any forum that I make my presentations outside institute, whenever I go, first thing I always talk about data gaps and the kind of data that I would like to receive as a demographer to understand health and epidemiology in this country. So I think we need to demand data, and just not demand data, but quality data, right? Because any data is not what we are looking for, but quality of data also is equally important. So that is the second point that I think I would like to reiterate on. And third thing that we want to probably reiterate is that whenever we think of policies and programs in this country, although we have been talking about communitization of the services right from our initiation of NRHM and now NHM, big, I think, talks and discussions almost on every platform after the NRHM was launched, communitization of the services, communitization of everything. Yes, we did that, but have we really achieved it? I think we need to re-introspect that very seriously. Whether Ashas have really served the purpose that they were meant for, I still see a lot of gaps in this. Now, in fact, what has happened actually on the ground realities is that there is a lot of conflict happening between ANMs and ASHA. And that has actually harmed the efforts than helping us. So I think we need to be more careful about this when we talk about communitization of programs and services. It is just not that you pass on the responsibility and wash your hands off. No, it rather calls for much bigger responsibility, a much bigger monitoring mechanism and supervision to ensure that they together are able to deliver what is expected. That is third point. The last point that I would want to raise is related to public health utilization and data from it. As Goli very nicely pointed out, yes, most of our health seekers are utilizing public health facilities. That's because either your public sector health facilities are non-existent. If at all they are existent, they are non-accessible. If at all they are accessible, they are not affordable. If one has to spend money in public health facilities, might as well prefer to go to a private health facility and pay slightly more, where at least you get some. So we need to, knowing this fact, we must bring in our public health facilities under regulation, which is currently completely, it's like at the loose end. Anybody in this country can open a hospital. To open a salon, maybe I need to follow a much stricter procedure than opening a dawakhana in this country. I think this is the time that we must regulate our private health sector and bring it under the monitoring and supervision of the system, so that we also get information coming out of that with respect to health indicators in this country. There are many other points, but I think these are the 4 key areas where I think we need to think very seriously and come up with some interventions, strategies, programs to improve our health data in this country. Thank you very much, sir.
Thank you, Dr. Professor Usha Ram. Really, we have enjoyed your presentation, the comprehensive coverage of various issues, as well as the
Sir.
participants presenting. Yes.
Sir, one question by Ajit Yadav. He's writing to me on WhatsApp. Give me a chance
But
to.
we have really run out
Okay.
of time.
Sir, he's already joined. You can just. Ajit.
Half a minute, Ajit ji, please.
Hello.
Yes, please.
Yeah.
Sir, I have one question regarding that infant mortality rate that is 17% coverage for any policy and program for any community. We have taken indicator infant mortality or maternal mortality. So if any policy or that 17% coverage of the infant mortality, so how much it is, I mean, success for any community or any health, I mean, it is coverage 17%.
Okay. I will answer that question in my
Yeah.
final comments. I got your point that in the civil registration coverage of infant mortality is very, very low.
Yeah,
But the program does not take into account civil registration estimates of infant
Absolutely.
mortality, nor civil registration estimates of death rates. They use the SRS estimates of infant mortality. So you need not worry about it. It is very sad that civil registration coverage is extremely poor, but that's so. Thank you very much, Usha. As
Thank you, sir.
chairperson, I am supposed to make some very brief comments at the end, and I will keep as brief as possible because
Sure,
we are run out of time. There are two issues basically. One is, yeah.
Can we go to our discussant for one minute and then to you?
Okay, if you have time, I thought
Yes.
we were running out of time because I don't know whether your time slot expires. I was worried about that.
No, sir.
Okay, then it's okay. I was concerned about time slot,
No, sir.
we switched off completely. So, okay. Yeah, Dr. Rattan Chand.
Yes. So, sir, let me also take
Brief
while
comment.
to also add few of the things if panelists can also add for way forward. What we are thinking of the insurance data, we have RSVY, private sector, and a lot of data coming from there also. And for the digital front, as Goli sir was also suggesting, now we are also coming up with things, national digital. How do our panelists see that as the data source going ahead? And on the private sector, really, be it Anganwadi workers, the payment becomes really a very tough point. So when we are also suggesting, be it our man force or also hospitals, they also complain ki paisa to mil nahi raha hai, to kaise jayenge, which brings to very important question which we are talking that for quite a few decades we have focused on birth rate a lot. And birth and women a lot, but what Professor Ram is also highlighting that we need to focus on well-being and also the mortality. And I would also ask this question to Kulkarni sir that is it really the time that we shift our focus to focusing more on death rate and well-being insurance, that kind of data, or what Goli sir is highlighting from his international experience that there is some lag in trust and confidence in our data, especially on this pandemic. So how to go forward as a way forward if our panelists want 2 minutes, please. Rattan sir, over to you to start with.
Okay, I think you have many points, but I will answer. I mean, the data quality, according to me, increases when you start using the data. You see, for example, HMIS data, if that is used for all sort of reviews, in monthly reviews, quarterly reviews at the senior level officer, then people will start reporting and also sending data and also see the problems in program implementation. So that is one aspect, I think. More you use the data and good quality data it becomes. This could also be the case with the surveys. And if the shortcoming, when researchers are using the surveys and they point out the shortcoming to the main agency which is conducting surveys, I think they can improve data collection and the survey methods in the future survey. Then also you said that insurance, yes, insurance, I think these important data, and but not we are not discussing here. It's a health economics subject, I think, but the data is very important. That's what I want to say. And someone pointed out this disaggregated data, service data. So far as this surveys data is concerned, there are there are indicators. There are, for example, scheduled caste, scheduled tribes, religion. You can classify like those. So you get all sort of reproductive child health data or other data. You can classify according to those classificatory variables. But in the HMIS data, which is service data, it is very difficult to get classificatory data because all this data is fed by the people who are not much acquainted with the with the data, and it is not possible for them to segregate data by so many variables at the service center. It will become possible when for each individual services are provided, and for each individual details are entered into the computer. If that data set becomes available in future, then you can do analysis by taking center from the data warehouse or from there. So these are my points. Thank you.
Thank you, Dr. Rattan Chand. Dr. Bakshi, any?
Ma'am, please unmute. Manorma, ma'am, unmute.
Yeah. Actually, I would like to raise my concern. Recently, like in April, like Prime Minister has introduced like the Integrated Information Health Platform, IIPS, wherein like we are expecting like the real-time data will be captured and it will track the 33 diseases. I think that it was actually refined version of the IDSP program. So, I mean, we have the expectations like maybe it will be more robust, and because the way it has been put up, like it will be actually grassroots level workers, they will have tablets and it will be online and like capturing the data from CSCs, PSCs and diagnostic labs. I would like to take it from, hear it from like Madam Usha Ram or Rattan Chand sir, definitely like how much successful or how much we can see it, because knowing that our internet, availability at the grassroots levels, and this program has been launched in a very big way. IIPS I'm talking about.
But please summarize.
Thank you. Anything Dr. Goli would like to add?
Yes, Goli sir, please.
Yeah, for last thing to me say is that, systems are in place. Only thing is we need a strong willingness from the government side and from the advocacy side. Even if they can estimate how much cost in terms of GDP, proportion of GDP spending is needed to make these systems perfect. I don't think that is a huge cost. So there is a huge willingness to make these systems work is very easy. But of course, that the strategies to how we can make them work is very important. So from the both sides, from the demanding side and from the supply side, somewhere we need to have an understanding. Only one example I'll give, this ICDS centers, that growth charts, children growth charts. I just recently looked at that data. It's an excellent data. It can easily be made useful for at least not for the entire India, but at least certain areas. Okay, wherever at least the ANM adopted villages, all ANM adopted villages data is of excellent quality, can be pulled and analyzed the child growth charts with even the dietary intake pattern, using dietary intake pattern data. So that's just one example I'm giving. Like that, you can, of course, make, see why when ANM adopted villages are working well, then why that process cannot be replicated in the same way to other villages? Not in the same way, but it's that same kind of strategy can be adopted for other villages, so that this kind of data generated from the existing system can be used. That's what
my experience has been from the ground level. I am talking about, Dr. Goli. In MP, like in 51 districts, it was decided by MP government that one collector will be in charge of one high priority districts. 17 high priority districts they had. My experience has been like when these high priority districts were looked after on RM and CHA, the other districts came down. So when we are talking about A&M adoption of certain kind of programs and they being successful, I think when we are pushing on whether it is the resources or the human resources in one district, the others go down because resources are diverted towards one thing and not towards the other. And India is like such a huge population. So how we are going to address it? Like either it has to be uniformity across to have the equitable and affordable and accessibility and having the services and diagnostics and other things across all along. That is what I feel, sir.
Thank you, ma'am. Kulkarni, sir, your turn to conclude. Sir, but you have gone on mute. Kulkarni, sir, if you can just check.
Yes. Now I'm unmuted. Fine.
Yes.
Okay. Now, just to conclude, we had a good presentation and good discussions, sometimes some debates also partly, and that is very healthy always. Basically, we do have a lot of data, as Professor Usha Ram has elaborately discussed, with certain weaknesses in practically every set of data, which is very common. And what we need to do is minimize these weaknesses. It is difficult to have something which is totally perfect. Censuses in the most developed countries, you have even higher omission rates than us. So there are issues. But essentially, there are two kinds of things. One is a complete enumeration like census and certain things, and other things are surveys. Now, if we want to just know the volume, the size at the disaggregated level, it is complete enumeration that is essential. Like census gives us information for every village. Somebody asked, what about information for my village? Yes, census gives information certain village, but on the limited variables. If we want to look at relationships, then complete enumeration is perhaps too difficult. The surveys provide a good instrument to look at relationships. But we are trying to use surveys to get disaggregated information to the extent possible. We have had some success, but we cannot get it all the time, particularly death rates, infant mortality rates, and so on. And same thing happens for morbidity rates or specific disease prevalence rates. For that, what we require is a complete enumeration or complete reporting. Dr. Goli mentioned public health and private health facilities, whether all of them report all morbidity, even for notified diseases, because for notified diseases, it is mandatory to report. But do they do it? So this is an issue. The same thing happens for infant mortality. It is supposed to be compulsory, but often it is not reported. And in such cases, one has to be more proactive in the sense, have a mechanism which would ensure as complete a coverage as possible. The census does it remarkably well, in spite of many people having complained and so on. It does remarkably well in getting the population enumeration and so on. But we have not been able to get it for events, vital events like births and deaths. Births have been successful fairly well. One of the reasons is the more births are now institutional, and that is one of the reasons. Children require birth certificate. There is a felt need. For deaths, for infant deaths, there is no felt need, and therefore one is not able to capture them. Only 17%. Even in Kerala, infant deaths are not really captured as well as others. So these are issues which we need to have, which means civil registration has to be strengthened in corporation level, municipal levels, and at state level. Yes, there are dedicated civil registration officers, but not at other places. At a village level, it is a village gram panchayat person, gram panchayat secretary, village accountant, teacher, or somebody, depending on the state, who is asked to do this. And this is not even 5% of the work of the person. There is no dedicated. You cannot have dedicated person, but then you must have good monitoring. We once requested that the Registrar General Office should provide one officer at each district at least to monitor the work of registration going on in this. And India's district is more than 2 million population, 20 lakh population. Have one monitoring so that one can go around and try to ensure more compliance, more registration. But anyway, there are difficulties. There are something which we cannot resolve. But basically, I feel the issue, but Dr. Usha mentioned, and there are various aspects and various kinds of data that we're collecting, that broadly I categorize into survey kind of thing and complete enumeration. And certain things we must go for complete enumeration. There is no compromise. SRS has been a compromise for 50 years now. It has been a compromise for 50 years. It was an interim arrangement as it was announced, and that now this is something that we need to get away with. And only then, only when there is dedication, there is a commitment from people involved in it that we must collect the data, we will not be able to get satisfactory data. Thank you very much, Dr. Arjun Kumar. My apologies for not keeping to the time.
It was quite required also, the time. Thank you so much. So now I invite Anshula to propose a formal vote of thanks. Anshula, over to you.
Thank you. On behalf of the IMPRI Generation Alpha Data Center, I would like to formally thank all of you for joining us today for this web policy talk. We are grateful to Professor Usha Ram, our speaker for today, for taking out the time to be with us and for delivering such an informative and enriching talk on the state of demographic and health data in India. Thank you, ma'am. We are grateful to Professor P.M. Kulkarni for chairing the session today and for adding his very rich insights to the deliberation. Thank you, sir. And of course, we are grateful to our discussants, Dr. Rattan Chand, Dr. Manorma Bakshi, and Dr. Srinivas Kohli, for sharing their perspectives and experiences as part of this discussion. Thank you. Thank you to our audience members here on Zoom or on Facebook Live who raised such pertinent questions and gave rise to such a thought-provoking discussion. Thank you very much. And of course, thank you if you're watching later on YouTube or listening to us on our podcast. We hope that you continue to tune in to future episodes of Data Discourses and our other web policy talks. Thank you very much, and I wish you all a good evening or a good night. Thank you.
Thank you.
Thank you.
Thank you, everyone. Please do share the recording with us later, whenever possible. Thank you very much. Thank you. Kulkarni sir, thank you very much for always being there.
Good. Enjoy.
So I want to tell Arjun, कुछ गलत बोला है तो सर की जिम्मेदारी है, क्योंकि जो सीखा उन्हीं से सीखा हुआ है। मैं हमेशा झाड़ लेती हूँ अपने हाथ भाई।
नहीं हमसे क्या कुछ नहीं है।
अगर गलती हुआ है तो सर ने किया, अच्छा किया तो मैंने किया, क्योंकि उन्होंने जो सिखाया वही सीख लिया।
हम आपके कभी टीचर नहीं थे।
No, but no, teacher is not always who teaches in class. You have taught me for my PhDs very personally and very closely, sir. I can never forget that. Even after my PhD, when I was working on my Lancet paper, it was you, the first person that I ever discussed the idea of that I intend to do this for my Lancet paper. So you have been my teacher always, 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 always. So इसलिए गलत बोला है तो मैंने बोला है, नहीं सर ने बोला है, अच्छा बोला है तो मैंने किया है, बोल देना भाई. So thank you very much, sir.
गलत तो होगा नहीं आपका.
Thank you, sir, very much.
Thank you, Goli sir, for joining.
I was worried because when I mentioned about the time, in at one place in Delhi, very well-known place,
yes,
the schedule was 5 to 7, and the discussion was continuing. And the people, staff came and told us.
Yes, they cut, sir. Yes. Yeah.
So we had to stop that at that stage. 5 to 7 means 5 to 7. So I was worried because I'm not familiar with this, web meeting seminars, whether they have certain very strict restrictions. So you will be automatically cut off. Before the speaker responds, or halfway through the speaker's response, they will cut off. I was really worried about that. But it's good we didn't have. We are not in that.
Thank you, everyone. As well.
Thank you. Such a delight.
Manorma, Goli, and Rattan Dada. Thank you. Thank you very much.
Thank you, ma'am.
Thank you, everyone. Thank you, Arjun. Bye. Good evening, and good night.
Bye.
Thank you.